right. Well, welcome everyone. Thank you so much for joining us today. We're going to go ahead and get started now that it's 12. So I'd like to start off and introduce myself. My name is Kimberly Makis, and I am a health educator at the Maxwell and Eleanor Blum Patient Family Learning Center at MGH.
My name is Mariam Taib, and I'm also a health educator here at the Blum Center.
All right, and just a few housekeeping items that we'd like to go over. So I just wanted to let everyone know that the session is being recorded for educational purposes. If you are interested in viewing this recording after, it will be made available on the Blum Center website at massgeneral.org/Blum Center. It will also be available on our YouTube channel, so the Mass General Hospital YouTube channel. Everyone is also in listen-only mode, so everyone has been muted to eliminate background noise so that we can hear our speakers. If you have a question, please use the chat feature at the bottom of your screen. Only the Blum Center staff, the co-host, and the guest speaker will see your questions, and we'll have time at the end of the session for them. Please do not share any medical, personal information or questions in the chat, and if you have a medical question, please ask your doctor. So without further ado, we'd like to introduce Susan Hernandez to begin her presentation.
Great, thank you everybody. Thank you for having me this afternoon. I will get started with sharing my screen. Here we go. So thank you again. I am Susan Hernandez. I am the chief of the midwifery service here at Mass General Hospital. And I've been a practicing nurse midwife for about 20 years. And my most recent years, in the 17 years that I've been here at Mass General. And I really am looking forward to the opportunity to share with you, with everyone today, my experiences in working and caring for women and families who are in recovery. To start my presentation today, I do want to acknowledge that throughout the presentation, and certainly in the title of my presentation, I refer to women, and I will use their pronoun series, the she pronoun series, to speak about women, but I do want to recognize that not all birthing people identify as women. And for the purposes of my talk, I'm sharing my experiences working with cis women in recovery. In our time together, these are a little bit of the background and the outline for our learning objectives. Essentially, to briefly discuss the background information on pregnant women and postpartum women with opioid use disorder and their experiences of recovery. Also discuss the profession of midwifery and what it has to offer this community of women and families. And also here at MGH, we have a special interdisciplinary team, our HOPE Clinic, which is designed to serve women and families and newborns in recovery, and to give me the chance to share about my work in this program. With the ever-evolving terminology and the field of addiction, I really wanted just to start with all of us having a collective understanding of the definition of addiction. So addiction is essentially, it's treatable chronic medical disease involving complex interactions among the brain circuits, genetics, the environment, and an individual's life experiences. People with addictions use substances or engage in behaviors that can become compulsive and often continue despite harmful consequences. What we understand about individuals experiencing problems with substance use is that about 25 to 50% of individuals will develop some level of either severe or chronic disorder. And like other chronic disorders, it's characterized by potentially progressive disease, episodes of remission, and also relapse, all which certainly require intensive treatment and ongoing care. And so in general, our approach is very similar to that of other chronic illnesses. And certainly addiction is a very treatable disease. Specifically with opiate use disorder, it's a chronic health condition characterized by tolerance, cravings, the inability to control or the continued use of opioids specifically, despite adverse consequences. Opioids can be essentially natural, synthetic, or semi-synthetic chemicals that interact with the various receptors throughout our body and the nerve cells in our brain and various organ systems, with the intention of reducing the intensity of both pain signals and our feelings of perceiving pain. This class of drug includes illicit drugs, some like heroin, or synthetic versions like fentanyl, as well as other medications that are readily prescribed and legally prescribed, such as oxycodone, hydrocodone, and codeine, to name a few. Prescription versions of these medications are generally safe when given in short durations or under the specific guidance and direction of their providers, but because they can also, in addition to reducing pain and controlling pain, they can also, for some people, produce euphoria and really have a high potential with that for misuse or possible addiction. Experiences of women with opioid use disorder, it's a significant part of the current epidemic that the United States and some parts of the world are really experiencing. We do know that opioid use disorder in women affects all racial and ethnic groups, as well as varied socioeconomic groups, and also women in different regional or demographic areas. Some of the statistics really in the last 20 years or so have become quite staggering. As you can see here in this study between this review from the CDC in the 16-year span, the rates of death from prescription overdose have increased about 471%. And the increase in death from synthetic opioids has increased a staggering and certainly very concerning 850%. A lot of the research, that I was able to come across really does note that there are differences in experiences of addiction between men and women. For example, for women, smaller amounts for less shortened period of time, it's possible for them to become addicted sooner. It's also noted that the brain changes because of opioids and women, between women and men, can be somewhat different. So really what this highlights is really a need for further research, certainly to tailor treatment and engagement and programs to the specific needs of women. With these increases in women and certainly in reproductive age women, it's easy to understand why the rates of opioid use disorder in pregnant women really parallel the general population. This chart and this study really looked at the national information on the prevalence of opioid use disorder at the time of delivery and the time of birth, and really in this 15-year time span, very similar to the last one that we just looked at, shows that there's really been about a 4-fold increase at the time of delivery. And with that, we can expect that for newborns, there's also been about a 4-fold increase in infants experiencing neonatal abstinence withdrawal syndrome in the same time frame. Untreated opioid use disorder is associated with with several high-risk pregnancy complications. Certainly here in pregnancy, we can see in untreated women higher rates of preterm labor or having the baby earlier, premature rupture of membranes where their water breaks at an earlier point in the pregnancy. And with prematurity, low birth weight, certain placental complications, and certainly the concern for stillbirth or fetal loss. With regards to the newborn, certainly there's the impact or the findings that are very common in newborns that are experiencing prematurity. Also the potential for birth defects. And then specifically at the time of birth for newborn opioid withdrawal syndrome, which is essentially a constellation of symptoms or various symptoms that is experienced by newborns as they adapt and transition from intrauterine or during the pregnancy opioid exposure. But not only for the pregnancy, but also not only for the newborn, but untreated addiction is also associated with engagement and some higher risk behaviors that also expose women to adverse either pregnancy or health consequences for themselves, such as sexually transmitted infections, such as HIV, other contagious infections, potentially violence or incarceration. And all these things collectively are potential to impact their own health and the health of their pregnancy. Certainly, opioid use disorder or substance use disorder rarely occurs in isolation. It's a complex disease with many complicated medical, behavioral, and mental health issues. Here you can see a list of some of the co-occurring and quite frequently mental health diagnoses that are also found in patients with substance use disorder and opioid use disorder specifically. This is certainly reflected in our HOPE population, in our cohort that we take care of in our clinic, where about 96% of our patients experience or have a documented psychiatric diagnosis. And specifically with anxiety and depression, about 86% of our patients have that diagnosis. And it's certainly well understood in the literature and that patients who have substance use disorders have a high likelihood at some point in their life having experienced a history of trauma, be it physical during their childhood or sexual at some point in their time. And certainly with that, we see high rates of post-traumatic stress disorder. And I would say our data supports that, and about close to 70% of our patients have a diagnosis related to PTSD. And additionally, we have about 36% of our patients have a diagnosis of bipolar disorder. And ultimately, certainly in our population with regards to their mental health histories, we've seen that about half of them have had an inpatient admission for a psychiatric hospitalization, and about 35% have a documented prior history of a suicide attempt. So, certainly one of our most significant goals of treatment and engagement is to help with these co-occurring conditions and psychiatric conditions as well. But accessing care isn't necessarily easy. There are significant barriers to accessing prenatal care. As I said, some of these comorbid conditions themselves make engagement and navigating the healthcare system difficult, as well as, several of our patients in this community also have several medical conditions, that make getting care difficult. For example, untreated post-traumatic stress disorder, PTSD, in and of itself is a contributing factor for accessing care late into pregnancy. Additionally, health equity researchers have really been doing a significant contribution to the literature and to the study of understanding how social determinants of health impact all marginalized groups, and I would include our patient population with facing a lot of these challenges: transportation, housing, transient housing, either transient housing, homelessness, or sheltered living, certainly food insecurities, and lack of resources. We also live in a very fragmented healthcare system, and there are few programs that offer integrated or co-located in the same place care for certainly pregnant women experiencing addiction. And additionally, there's a lot of barriers to accessing care experienced by our by our patients because of the stigma of their disease and the fear of judgment and receiving, heavily biased care. that can really prevent women and pregnant women specifically from engaging into prenatal care. Certainly, some of our patients have had prior experiences with the DCF system and some of those systems, and having either the fear of loss of their children, their current children, or the newborn to come, and that fear is real, and it can keep women from engaging, which can be extremely difficult. And certainly not, there are also legal barriers. 18 states include prenatal care or prenatal substance use, as a definition of child abuse and under civil statutes. And additionally, about 3 states consider it grounds for civil commitment during pregnancy. Massachusetts is not necessarily one of those states, but I would argue that some of our reporting requirements for women in treatment and some of the accessing medicinal treatment during their recovery really can become a barrier to accessing care for our patients. Additionally, COVID-19 has provided us with a new level of complexity for a lot of our patients seeking care. It can become a significant challenge. This was an article that I came across that shared the story of somebody named Carrie Dahl. And this is her and her 8-month-old daughter. She herself is in recovery for about 5 years, and she works as a recovery doula at one of my colleagues' prenatal sites out in Western Massachusetts. And the article really outlined very well, how the COVID-19 pandemic and the decrease in personal contact has impacted the recovery community. Certainly, a lot of the essential networks and the social networks that women in recovery have put in place have been displaced because of COVID and other social distancing requirements. And certainly, not to mention the stress, both personal and for many economic, that our patients are experiencing. Additionally, isolation is a real issue, and it can certainly in a population that has high rates of depression, anxiety. I think that the isolation during the COVID pandemic has been especially impactful for them. And additionally, we've also seen the difficulty for a lot of our patients, in the setting of the COVID pandemic with navigating the DCF system. Some have experienced the loss of visitation because of social distancing requirements, as well as delayed unifications, certainly, which can be very, very traumatic and very difficult for our patients to experience. But pregnancy is also an opportunity. This is a time when a lot of women experience a lot of motivation to make changes in their life. Additionally, it's an opportunity or a junction in the lives of women where we can screen for substance use, we can offer treatment, and ultimately engagement at this time as women potentially find out when they find out that they're newly pregnant. It's pretty universal. I mean, women make a lot of changes ultimately to optimize their health and the health of their babies with diet, nutrition, exercise, decreasing smoking, finding new housing situations. So it is especially important for this patient population that we recognize and we offer treatment and engagement at a junction that might capitalize on natural changes that people would want to make for their well-being and during the pregnancy. So this brings me to the practice of midwifery. And so with pregnancy midwifery, midwifery as practiced by certified nurse midwives, which is what I am and what we have here at Mass General. It's essentially the compassionate care of reproductive age women, their newborns and families across the care continuum of pre-pregnancy, pregnancy, birth, postpartum, and into the early weeks of life for the newborn. midwifery has been around for centuries, and globally, the majority of women are delivered and babies are delivered by nurse midwives or midwives. It is a graduate level education where we study both nursing and midwifery. Here in the Commonwealth, we've been licensed, again, we've been around for a long time, but we've been licensed since the 1970s. But an important point for us was in 2014 when nurse midwives here in Massachusetts were granted independent licensing. And so what that means for us is that our practice does not require physician supervision, but rather close collaboration and a clinical relationship with our physician, obstetrician gynecologist colleagues. Another important milestone that I'd like to recognize was in 2016 with the CARA Act. Nurse midwives were granted the opportunity to become buprenorphine prescribers for women with opioid disorder. And certainly that was seen as necessary to help increase access to treatment for reproductive age women. So who are we here at MGH? These are some of my colleagues. The nurse midwifery service here at Mass General delivers anywhere from 900 to about 1,000 babies annually. And we have since 1994 when the practice started. We have one of the largest collaborative practices and one of the oldest and largest collaborative practices at here in Boston with 23 midwives practicing here at Mass General. Our outpatient sites, so where we see women prenatally, are mostly in the community health centers of Chelsea, Revere, Charlestown. But additionally, we see patients here on the main campus, as well as Waltham, and soon to be out in Danvers. We will be starting care at that new site. On the inpatient unit, so at the hospital, we also take care of our own patients, our own midwifery patients, independently for labor and delivery. And additionally, we are the primary postpartum rounders, so provide that initial postpartum care for the majority of patients who deliver within the obstetric service at Mass General Hospital. So the midwifery model of care is essentially a framework or our values that we hold as a profession. Similar to the Hippocratic Oath for physicians. These are the tenets that help define the practice of midwifery. There's about 11 hallmarks, but I've just chosen to highlight today, about 8, because they really apply to my work and to our work in practicing with and caring for women with in recovery. Certainly the recognition that pregnancy and birth is a normal physiological and developmental process. Nurse midwives are expert in normal pregnancy. That is what we are educated to, and that's where our skills are honed and, like I said, educated to. The promotion of family-centered care, recognizing that women, birthing people live within the context of their family, and recognizing the importance of engaging partners or whatever supports identified by the patient into their care. And the empowerment of women as partners in that healthcare. This is building the trust and the trusting therapeutic relationship with our patients. Care of the vulnerable populations. Like I said, the majority of our service practices out of the health center and cares for a wide variety of community-based populations. The continuity of care, it's important that we, throughout the arc of pregnancy and throughout the arc of women's reproductive lives, take care through the pregnancy and the different stages that women might need us from teenage adolescence through to menopause. I would say we're all strong advocates for informed choice and the right to self-determination. This is where women, where you listen to women and listen to their concerns and have them as the driver of their healthcare needs. a lot of what we focus on during our care of women is teaching and guidance and anticipatory guidance and what can be expected to be normal and, you know, heavy into understanding the value of counseling and education as part of women's health. And finally, certainly collaboration with other members of the healthcare team. Recognizing that different needs might be met by different parts of the team, and we focus and certainly are educated to the art of consultation and co-management in the care of some of our more complex patients. So, you know, these are the values that I draw on for myself as I care for women in recovery. So, pregnancy is already a vulnerable time for many women, and women in recovery can really experience this as like exquisitely so. Trauma-aware, trauma-informed care this is a framework, you know, set with these 6 principles of self-safety, trust, mutual help, collaboration, empowerment, voice, and recognition of all the expressions of people in their lives. And trauma-informed care offers us a realization and a framework for realizing the impact of trauma and understanding that trauma as it plays out in terms of its impact on individual recovery. Part of what we do within the trauma-aware and trauma-informed care model is recognize the signs and symptoms of trauma and how they might express themselves as patients engage in care or experience different things within their health. You know, for example, you know, a lot of what we do in obstetrics and gynecology, things like pelvic exams or other invasive procedures, you know, might be perceived, you know, very differently with somebody with a trauma history. Certain body changes, things like prior losses or difficult outcomes, you know, can be incredibly triggering for women, for all women, but potentially for women with a trauma history. So truly from this and this framework of being trauma aware, it's really our responsibility as clinicians and providers to respond in all of our clinical efforts, be they our policies, whatever procedures that we develop, as well as how we incorporate trauma awareness into our practice, you know, with the active goal of avoiding re-traumatization. And for myself, this framework, you know, fits very fluidly with my understanding of myself and my professional self and my definition of being a midwife. So this brings me to my Wednesday clinical day. And I get to work in the HOPE Clinic. And as you can see here, what that stands for is Harnessing Support for Opioid and Substance Use Disorder in Pregnancy and Early Childhood. This is an interdisciplinary clinic that was developed as part of the larger SEDS initiative through the hospital and started in around 2017 and 18 with the goal of serving women, newborns, and families, including partners in recovery. This is who we are. Like I said, we are a large team, and our team functions under this integrated care model. So we have obstetrics, myself, and MFM that provides the prenatal care, addiction medicine, as well as psychiatry and mental health services. We also offer newborn medicine, pediatric, and internal medicine. So listed here are some of our key collaborators in the comprehensive treatment that we offer, this sort of surround sound, surround care for our patients. And some of the team members are inpatient and outpatient that we closely collaborate with. Truly integrated care has been shown to not only increase access and engagement with treatment, but also to increase the quality of care that women in recovery receive. So our program has 5 key components in its design and its values and priorities, making us quite unique, certainly complicated or a little bit complex, but all important. And we think of the whole family unit is a value that it's not only just the woman or the newborn or the partner. It's, how can we care for the family in its entirety? We also have a low threshold and trauma-informed flexible model that as patients, we certainly start with a schedule, but it doesn't always work out that way. And we just, meet women where they are and try to work with them at whatever stage they are with their own either interest or capacity for engagement. And our doors are truly always open. It's also part of our structure is the importance of interdisciplinary and collaborative care, recognizing that with a complex patient population, everybody has a specialty, and we talk quite freely, share clinical information, the plans, the happenings in our patients from a multidimensional, multidisciplinary approach to maximize all the offerings, for wellness. Again, the arc of care in our HOPE model is quite unique. It starts from preconception, pregnancy, and that doesn't end when the baby's here. We continue through to postpartum and to early childhood through a span of up to 2 years post-delivery and 2 years of newborn life. Another factor for our program is that I see us really working hard on a continual basis to reevaluate our program and focus on knowing that what we're doing is, or thinking what we know is right for our patients, and using a trauma-informed framework that isn't something static. It's a continual lens that we really try and evaluate ourselves with, so that we can be assured that we're meeting the needs of our patients in a productive and healthy manner. So placing obstetrics in a prenatal care in a sort of specialized bringing together of, maternity care and addiction medicine has been proven to really improve outcomes. This is some information shared through a large study out of Kaiser in California that really showed improved outcomes such as increasing birth weight, increasing length of gestation, so less preterm labor, so women stayed pregnant longer with less preterm deliveries, fewer rates of placental abruption specifically, a complication that can be quite significant, as well as decreased fetal loss and lessened hospitalization time for the newborns experiencing newborn withdrawal syndrome. But not only did the study realize and find that there were improved outcomes for women, there were also improved patient satisfaction and really improved participation and engagement in the prenatal program. So what does care for patients pregnant patients with opioid use disorder, what does that look like? So certainly the cornerstones of care are pharmacological treatment with opioid agonist, which is supported by a large body of evidence to be effective and safe. Methadone and buprenorphine specifically are the standard of care in caring for women with this disease, in combination with behavioral therapy as well as you know, focusing on treatment and offering treatment for mental health diagnoses. Ultimately, the goal of treatment with medication used for opioid use disorder is, you know, preventing cycles of relapse or withdrawal, or preventing and managing cravings that patients might experience and often do experience, as well as stabilization, so to decrease the likelihood of engaging in other potentially risky behaviors. And ultimately, treatment also offers improved adherence to either prenatal care or prenatal care, or also recovery programs. And certainly with these goals in mind, we will see improved outcomes and fewer adverse obstetrical outcomes with treatment. So in caring for our patients with substance use disorder in our clinic and HOPE, certainly all the collaborations are incredibly important, but as a nurse midwife, one of the key collaborations and partnership really, it's almost beyond collaboration, it's truly a partnership, is with my fetal medicine colleague. This is Sarah Bernstein, who is the obstetrical director of the HOPE Clinic. And maternal fetal medicine specialists are physicians and obstetrician gynecologists that have gone for additional training and specialized training to be high-risk pregnancy providers. You know, given some of the medical and obstetrical complications that sometimes arise in this patient population, it's incredibly important to have a maternal fetal medicine specialist involved in the care of patients, along with myself as a midwife, to offer, you know, guidance and planning around a lot of the potential complications or medical things that can develop in the lives of women with this disease. So truly together, she and I see all of our obstetric patients in the HOPE Clinic. Sometimes they see both of us, and we'll meet both of us throughout the pregnancy, and we have alternating visits where we get to care for our patients together. So this is certainly a very valuable model for a midwife to have, you know, embedded in such nice collaboration with my physician colleague. So components of our prenatal care during pregnancy are, you know, the nuts and bolts of it are very similar to, you know, what all women experience in terms of, you know, routine prenatal care, with some twists. I would say that the care that we provide is highly individualized, given some of the medical and psychiatric or obstetrical complications or histories that women come to us with. So with that, often as women might be engaging in recovery for the first time through the pregnancy and through at this point, we have, you know, an opportunity for increased engagement, as well as, you know, increased appointments. Sometimes in routine prenatal care, you might go a month without care, and I would say that it's extremely rare for us. We usually see patients potentially at least every 2 weeks, if not weekly, depending on what the needs are of each patient individually. Part of what we also do is have more ultrasounds. That's a way for us to identify some of the growth issues that some of our pregnancies or some of the pregnancies might experience. So they have a little bit more monitoring in pregnancy. We also offer all of our patients an opportunity to meet with the inpatient anesthesia team, our physician colleagues, during the pregnancy to discuss any concerns with pain management during labor, so recognizing, or during their admission, depending, recognizing that sometimes women who are on maintenance therapy of methadone or buprenorphine might have different medical needs with regards to how to manage their pain. One of the things that we also offer as a framework in our clinic is a visit with the pediatrician before delivery, to sort of get a chance to talk about what the pathway for the baby is going to be, what's the treatment for the baby, having a sense of what either medicinal treatments, breastfeeding, or just general care the baby might experience as a newborn in those first few weeks, where it might have a longer evaluation or potentially a longer stay in the hospital. Certainly, as I said, a lot of what I do is some case management and offering a lot of guidance and counseling for our patients during pregnancy. Even from many years of working with high-risk patient population, I've always found that even the most complicated pregnancies, women still value understanding what pieces, I mean, they might have this one aspect or several aspects of their pregnancy that, you know, makes them either high risk or more complicated. All women value and can find value in understanding those other elements of their pregnancy that just might be normal, and normal discomforts, and you know, those sweet moments of like feeling the baby move, or, you know, what position the baby's in. There's still even in our most complicated patients, an opportunity to share and help women enjoy their pregnancies as a normal experience. Additionally, a lot of the discomforts of pregnancy that some women experience can be very similar to some of the medication side effects of either methadone or buprenorphine, for example, hot flashes or constipation. And these are also things that happen to women, you know, in pregnancy. So it's an opportunity to sort of offer teaching on the relief measures and different management that might be hard to sort of tease out. Is it medication or is it pregnancy? But a lot of what I do is helping them understand and contextualize those things, you know, in the course of their pregnancy. Something else that we see quite frequently also with medications for opioid use and treatment, use disorder treatment, is sometimes because of pregnancy and the increasing blood volume and the increasing metabolism that happens to all pregnant women, sometimes there's requirements for increasing dosing to help, you know, stave off either cravings or withdrawal symptoms. So, you know, certainly with my addiction medicine colleague or the methadone clinics, you know, managing that, but I help put it within the context of the pregnancy and normalize it as just the medication needs are going up because of the pregnancy. And sometimes a lot of women can find this quite distressing because the numbers seem startling. But just, again, grounding it in education and offering women the opportunity to ask questions and learn more about their pregnancy and their bodies in the course of their recovery. One of the things that I work quite heavily on with our patients is anticipatory teaching about what to expect on labor and delivery. Depending on their risk criteria, women can deliver with either the midwives, if they so choose, or the physician team. It just depends on sort of what if any, risk factors they bring to the delivery, but some women do have that choice. And one of the things that you can see here is the birth plan that I've worked on developing and bringing forth to the patients. Is a communication tool. It's, you know, the birth plans are a communication tool to help women communicate with the inpatient team. It gets them, we start having a discussion about thinking about how do they cope, what things are important to them, what have they prioritized for their wishes for their birth experience. You know, what do they know about themselves in terms of sensory, the loud noises, lights, do they want things dimmed, hot compresses, warm compresses, you know, certain things that can bring them relief. All women come with the skills of understanding themselves, and this is just a tool to help them put it onto paper again, to communicate with. Additionally, in this document, I have shared and I talk patients through different mindfulness or relaxation programs to help them prepare for childbirth. Tools, these are all just tools to keep in their trove to bring with them to their birth experience. And ultimately, also on that list, there's a list of some affirmations, just, you know, positive sort of self-compassionate words that they can, when they're in either a spiral or a spin or, you know, negative thinking or anxiety potentially about what's coming in terms of their birth. Just, you know, kind words that they can say to themselves to just, you know, stay in the moment and plan for, you know, as they plan for their delivery. Also, the nurse midwifery program here at Maternal has a really nice partnership with a volunteer doula service. Doulas are women, or mostly women, who are specialists in comfort relief measures during pregnancy. And what I can do is make a referral and a connection to this service. And they'll offer women, these women have offered up and volunteered their time to be there for our patients. And it's a referral that, depending on what patients choose, I go over it. Some choose it, some people don't. But it's an extra support for some of our more medically and socially complex patients. And it's a nice offering that several of our patients have taken us up on. About 50% of pregnancies in the United States are unplanned. And some of the statistics for our patients with substance use disorder, it's as high as 80%. So a fair amount of the time that I spent with patients in the third trimester is just offering education on different methods of family planning. It's when we start the discussion that we keep it patient focused and just offer information for what are their thoughts for planning their family, for future childbirth, for you know, controlling their reproductive lives. Additionally, we have an inpatient access to some of our what are called LARCs, or long-acting reversible contraception. Those are things like IUDs, which are intrauterine devices, or Nexplanon. These are devices that can be put in by providers and offer long methods of family planning or birth control that are ultimately reversible. One of the things that I'm always very mindful of when engaging in any conversation with any woman, but engaging in a conversation about birth control is really to provide, as best I can, unbiased information and unbiased care. Certainly, some device, you know, things like the devices that require providers, the LARC devices that require providers to put in and take out, where women are dependent on us as providers for access or unaccess, is very different than just stopping a method or not using a method, is that these methods are very sort of susceptible to potentially coercive practices since patients can't control them for themselves. So certainly with any of my patients, I say these are methods that we will put in as you would like, and we will take out as you will like, recognizing that really women need to be the drivers of and the ultimate decision makers for their own reproductive lives. Additionally, I think being thoughtful too of the messaging. Certainly a lot of women in recovery are, through a variety of means, or in recovery or struggling with recovery, get the messages that they shouldn't be mothers or they can't be mothers. So it's even all the more important to provide shared decision making and informed consent with this population of women. Breastfeeding is encouraged and certainly not contraindicated. It's beneficial to many babies and moms who are taking medications for opioid use disorder. What we see and can see is decreases in severity of newborn opioid withdrawal syndrome, sometimes less need for pharmacotherapy or medicines for the baby during their admission, and shorter hospital stays for babies. And not to mention many of the other known immunological or health benefits that we know are the result of breastfeeding for newborn. As a midwife, I talk to them about the benefits of breastfeeding. And a lot of women in our program actually find it empowering to know that they can be a part of the baby's treatment. Mass General Hospital is a breastfeeding friendly hospital. We have policies that encourage skin to skin, which is placing the baby with a mom, uninterrupted for an hour to help them with that initial transition. Additionally, rooming in, meaning that the baby stays close to the mom or in the room with the mom so that they can be receptive to some of the feeding cues from the baby. So certainly a lot of our design through obstetrics and pediatrics and internal medicine is very supportive of breastfeeding in our clinic. But that said, I also want to recognize that this is a population that has low rates of breastfeeding initiation because of some of the barriers. For some women, there's a lot of lack of information. Additionally, some of the policies in the residential treatment programs, if that's where women are housed, require them to be at the programming and engaging in the treatment there, and that means that they can't necessarily be at the bedside or as much as we'd like. Additionally, some of navigating some of the hours and the access to methadone clinics, that is something else that can keep women, new moms away from the bedside to support ideally breastfeeding is on demand. So really, ultimately for us, the goal is ongoing support and ultimately respect for however the mother chooses to feed and whatever choices that they choose to make with regard to infant nutrition and feeding. Certainly postpartum care is part of, we provide postpartum care and post-delivery in the same sort of routine fashion and do the routine elements. Other than, I would say, again, this is another junction where we really heighten our availability and appointment times for patients, enacting, this is a time where we can actualize family planning needs. But really, a lot of the research in the most recent times is increasing how vulnerable the postpartum time is for all women, but certainly for women in recovery. It's a time where women are vulnerable to the potential relapse, certainly things that are barriers to care, sleep deprivation, which can be incredibly disorienting for some women with mental health diagnoses. So more than any other time, we do a fair amount of screening for perinatal mood disorders and screening and a heavy screening at all the different junctions of care, whether that be through psychiatry or social work, certainly with our wonderful recovery coaches, screening and a vigilance for postpartum depression or anxiety disorders. I'm sharing here a slide, research by Dr. Schiff and some of her colleagues. Dr. Schiff is the medical director as well as the pediatrician in the HOPE team, just highlighting how vulnerable women in recovery are during the postpartum time. It really highlights that the highest risk for overdose and for morbidity has been identified from the 7 to 12 months postpartum. So it's all the more important in our program for high engagement during this time from the different disciplines to help mitigate some of these risks during this high risk time. So we have a high touch model, and again, because of what we know of the postpartum time, the arc of care really continues for 2 years, and it really allows for the continued care of the whole family for those 2 years. And listed here are some of the supports that we really leverage during the 2-year time frame as we care for and continue to care for women post-recovery. So I want to end with this. This is a statement from an organization called Sister Song, which is a maternal health and reproductive justice advocacy group. And certainly this is the lens that I bring to my work, and I would argue that we all bring to our work within the HOPE team, is the belief that all women have the rights to have children or not have children, and that those children, that they themselves have the right to nurture those children in healthy and safe environments, and making decisions for themselves and their own treatment. And these are essentially human rights. And with that, we should be thoughtful to the systems of power that our patients engage in or come across, and we certainly work as advocates to help them navigate those systems. And ultimately to centralize the voices of women in recovery as the drivers of their own health and the health of their families. So thank you so much for this opportunity to share with you all today.
All right, thank you so much, Susan, for that informative presentation. We do have a few minutes for questions, so I'll just jump right into that. Let's see. The first question is, how do you handle a woman in active labor that is an active drug user?
So, I mean, I would say we handle them the same way we handle all women. We are mindful of what their medical condition is and offer, them the support that they would need. A patient who is unstable in her recovery would be managed on labor and delivery by our physician colleagues or MFM colleagues. The nurse midwifery service, that would be a sort of a risk category for them to be cared for by physicians. But the care is the same. We support them. We offer them whatever medical treatment they might need in that moment to help with what they're experiencing medically. So certainly there's certain protocols that women would need, or medical protocols that would be applicable to this patient population or to that patient. But we would care for them, with the same compassion and expertise that would be required. But they would be on labor and delivery. Those patients would be managed by our physician colleagues.
All right, thank you for that. Do you work with your patients on the newly required plan of safe care?
We do. So usually that is navigated. We start touching base with all our patients on making a plan for their recovery portfolios and identify who their support systems are and who they're within either programs or within other opportunities of outpatient programs. So we do that. I myself don't usually navigate that. That is usually done between our recovery coaches as well as my social work colleagues in the HOPE team. They're the ones that help sort of put that in place, as well as our addiction medicine physician put that all in place so that patients have to take that into their plan of care with their admission.
Mm-hmm. Another question is, do you offer abortions or assist patients in accessing abortion during treatment? For example, if a long-term patient has a 13-month-old and is pregnant again, would abortion access be an aspect of her care?
So I would say with all pregnancies, a lot of the discussion starts with what their intentions are for the pregnancy, and certainly if a patient makes the decision that it's not the right time or they would like the option and choice of termination, we do have pathways within our program to help them in a sort of seamless way, access in a low barrier way for them to access terminations for their pregnancy, if that's where they would like to go and what they would want and or need. So we do have like a low barrier pathway that that does exist, and we talk about and offer them the healthcare that they need.
Okay, and with that, we are at the end of our session. I just want to thank you again, Susan, for the presentation, as well as the audience for participating. So thank you all so much, and I hope you all have a nice day.
Thank you so much for having me.
Thank you.